Hello, everyone. Good day to you all. So, today we are going to discuss hypertension or high blood pressure. You probably have a family member, a parent, a grandparent who is experiencing this kind of cardiovascular disease. So, what is it all about? Hypertension is a sustained elevated systemic arterial pressure. So diastolic elevation is more serious. So we reflect here on the pressure on the arterial wall during the resting phase of the cardiac cycle. And there is a persistent elevation of blood pressure for two or more consecutive readings. So if you found out that the patient has increased blood pressure, and it's more than what is normal. It's more than 120 over 80. That's the normal one. And if you have two or more readings of more than that, most probably the patient is suffering from hypertension. So, classifications according to the type and severity. There is number one, systolic and diastolic hypertension. Letter A, systolic hypertension is the systolic blood pressure of 140 millimeter mercury or higher. So if you have this value on your systolic blood pressure, that is considered systolic hypertension. But for the diastolic hypertension, if your diastolic blood pressure is above 90 millimeter mercury or higher, it means that you're experiencing diastolic hypertension. And number two, we have primary and secondary hypertension. When we talk all about primary hypertension, this is also known as essential or idiopathic from the word itself, idiopathic. Idio means unknown. So we don't know what the cause is all about. That's why it's idiopathic. So this occurs in 90 to 95% of patients. So maybe some of your parents, some of your grandparents, your other relatives might be suffering from this, from primary hypertension. Like what I've said, the etiology is unknown. Diastolic pressure is more than or equal to 90 millimeter mercury. And from tests, they can do tests to determine what is causing the hypertension. They can do serum tests. Like, for example, they're going to test your blood cholesterol levels. If they are increased, they are going to test your kidney functioning, your liver functioning, your ECG. Several tests are going to be done in order for you to be diagnosed with primary hypertension. And if the doctor cannot determine the cause of hypertension, then this would be the diagnosis. But if there is a known cause for it, usually 5 to 10% of cases have secondary hypertension brought about by renal problems, endocrine problems such as diabetes mellitus, neurogenic or cardiac in origin. The white coat hypertension. This is the type of hypertension where a person who is actually normotensive, so they have a normal blood pressure, but their blood pressure increases when they are measured by a healthcare professional. So they are nervous around healthcare professionals. Some people are like this. This is just psychological. Fourth is malignant hypertension. It's uncontrollable and may arise from both types. Um, and there can be certain drugs that can cause this, such as anesthesia. And an emergency condition characterized by diastolic blood pressure of more than 120 millimeter mercury. Remember, that's already 40 values above 80 millimeter mercury. So that is very, very dangerous. It can be fatal because who knows? The arteries might weaken and rupture later on. Labile or pre-hypertensive. It's a fluctuating from the word itself, labile, fluctuating. So it means it goes to and fro. Fluctuating blood pressure increases during stress, otherwise normal or near normal. So that's labile hypertension. Now, we go to the values of the normal pre-hypertensive state, stage 1 and stage 2 of hypertension. For the normal, as we all well know since we were in first year of college, or if you've studied this in health in high school, the normal blood pressure of a person, an adult person, is at 120 for the systolic and 80 for the diastolic. For the pre-hypertensive state, if you have a value of 120 to 139 for the systolic or 80 to 89 for the diastolic, then you are in the pre-hypertensive state. For stage 1, that's 140 to 159 for the systolic, 90 to 99 for the diastolic pressure, and for stage 2, it's equal or more than 160 for the systolic and equal or more than 100 for the diastolic. Risk factors, the non-modifiable ones. When you say non-modifiable, again, these are the factors that cannot be changed, such as the family history. If you have a family member, such as your parents, your brother, or your sister is suffering from hypertension, then most likely you will be having it as well. The age, as we all grow older, we are susceptible to have hypertension. What else? The sex or the gender. Males are more susceptible in developing hypertension than females. And the ethnic group. African Americans or the blacks, they are more susceptible in developing hypertension. Now we go to the modifiable ones. Stress can cause hypertension. So if you are a workaholic, you work a lot with no rest, with no play at all, with no stress relieving activities, you are going to suffer from hypertension. Obesity as well can lead to hypertension. With all of the fat that you have, you will develop, or your most probably your LDLs will be increased, contributing to the increase in the blood pressure. Your diet, if you are having a diet high in saturated fats or um, fast food, if you're fond of eating too much fast food, you're fond of eating in McDonald's, burgers, fries, donuts, and so on. These are foods that are rich in fats, then this can lead to hypertension later on. Or those who are living a sedentary lifestyle. All you do all day is to sleep, or if not sleeping, you eat and do Netflix and chill, then you are going to suffer from hypertension later on because our body is programmed to do exercise every day, at least 30 minutes of exercise every day. And if you don't do that, you are going to suffer from hypertension. Substance or drug use as well can contribute to the development of hypertension, such as cigarette smoking, alcoholism, those who are using birth control pills, or those who are addicted to caffeine, like me. Sometimes my blood pressure is going to shoot up due to too much caffeine in my blood. I drink around 4 to 5, not cups, but mugs of coffee. And that's not just instant coffee, that's brewed coffee per day. So sometimes my blood pressure shoots up. So I need to watch that out. I'm controlling my caffeine intake now to just 1 to 2 mugs per day, unlike before. Now, the pathophysiology. We have number one, the arterial baroreceptor system. Number two, the renin angiotensin aldosterone system, or the RAAS. So here we go regarding the pathophysiology of, or this is the renin angiotensin aldosterone system. Now we start out with the drop in the blood pressure. If there is a drop in the blood pressure, it's the function, one of the functions of the kidney is to release renin. Now, that angiotensinogen, which is produced by the liver, is going to be converted by the renin into angiotensin 1. And once the angiotensin 1 reaches the lungs, it's going to be converted by the ACE. Take note, the ACE. What does ACE stand for? Angiotensin converting enzyme. So, angiotensin 1 needs ACE in order for it to be converted to angiotensin 2. Now, what does angiotensin 2 do to our body? It causes the hypothalamus to stimulate it in order for us to be thirsty. So the more we thirst, the more we drink water. What else does it do? It causes our blood vessels to constrict. There's vasoconstriction. So if there's vasoconstriction together with more water in the body, that would lead to elevated blood pressure. What else does it influence? Angiotensin 2 influences the adrenal cortex to release aldosterone. And what is the function of this hormone? Aldosterone causes the kidneys to retain sodium. Of course, sodium is married with water, so there's sodium and water retention, causing an overall elevation in our blood pressure. This is what the renin angiotensin aldosterone system is all about. Okay, now we go to this, the arterial baroreceptor system. Now we have two things here, the sympathetic and the parasympathetic system. As we all well know, once the sympathetic nervous system is activated, there's an increase in the heart rate, including the contractility. But once the parasympathetic system or nervous system is activated, there will be a decrease in the heart rate and cardiac contractility. Now, for the parasympathetic nervous system, or for this whole thing, arterial baroreceptor system, there are baroreceptors found on on the aortic arch and the carotid sinus. What do they do? These baroreceptors, based from the word itself, baro is pertaining to pressure. They monitor the pressure or the blood pressure in these blood vessels. And what do? They they influence, or they tell the cardiovascular system in coordination with the brain when to increase or decrease the blood pressure. So, let's say, for example, if there is an increase in blood pressure brought about by sympathetic nervous system stimulation, the baroreceptors are the ones that are going to detect it and tell the brain that there is an increase in the blood pressure. So it's going to tell the brain that. It's going to relay that information. Now, once the brain has received that information due to the increase in blood pressure, it will now tell the parasympathetic nervous system via the cardioinhibitory center of the vasomotor area through the cranial nerve number 10 and cranial nerve number 9, the glossopharyngeal nerve and the vagus nerve, to tell the heart and the blood vessels to decrease heart rate and contractility together with the decreasing in the blood pressure as well. That's what these things do. So that's all about the baroreceptor system. But before we proceed, these baroreceptors, they can adapt to what is happening with the cardiovascular system. They might think that 140 over 90 blood pressure may be normal. And if these bioreceptors think that what the pressure 140 over 90 is already normal, it will no longer send those impulses to the brain. That's why hypertension is continuously occurring in a patient because these baroreceptor cells, they have adapted to the constant increase in the blood pressure of the patient. So that's the danger there. Now, clinical manifestations, subjective signs and symptoms. The patient will commonly feel headache, where usually at the back of the head at the occiput. There's lightheadedness. There's tinnitus, easy fatigability due to decrease in the circulating blood brought about by constricted arteries. There is visual disturbances. For severe hypertension, they can see spots or flashing of light within their field of vision. There is palpitations and brief lapses in memory, but that rarely occurs. Objective clinical manifestations, of course, blood pressure that is greater than 140 over 90 millimeter mercury, retinal changes, but that is already for late stage of hypertension, possible hematuria, and cardiac hypertrophy if hypertension is left untreated. Now, what do we do? Lifestyle modification is, of course, needed by the patient. It's one of our management for these patients. If they are fond of eating fast food, they need to change that in having a healthy and balanced diet. Weight reduction if they are obese or overweight. By doing what? Exercise, which is also mentioned here. At least 30 minutes of exercise per day should be done by the patient. Sodium restriction, of course, should be done. Dietary fat modification if they have increase in their total blood cholesterol. Relaxation techniques if they always feel stressed. And of course, smoking cessation because this can aggravate the hypertension of the patient for those who are smoking. Now, we go to the anti-hypertensive drugs. Number one, we have the alpha adrenergic blockers. What is the action? They decrease the peripheral vascular resistance and it relaxes both the smooth muscles of the bladder and the prostate. So these are medications that always end in sin. Sin, 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 sin. There's a suffix of sin. Examples are alfuzosin, doxazosin, prazosin, tamsulosin, terazosin, and silodosin. Remember, alpha adrenergic blockers, they always end in the suffix sin. Number two, central alpha agonists. Action is they decrease the release of adrenergic hormones from the brain, the medulla oblongata, which decreases peripheral vascular resistance and reduces cardiac contractility. What are examples of drugs under this? We have catapress or clonidine, catapress, guanabens, whitensin, and methyldopa aldomit. Now, we are going to teach the patient to take the last dose of this drug of last dose of the day at bedtime in order to minimize drowsiness during the day. So tell the patient to take this at bedtime to minimize drowsiness during the day. Now we go to the beta blockers or beta adrenergic blockers. Action of these drugs are the following. They exert anti-hypertensive effects by doing, they reduce cardiac contractility. They also reduce the release of renin from the kidneys. They reduce the cardiac output. Examples of drugs from beta blockers are the ones always ending in olol, like metropolol, propranolol, nadolol. These are examples of our beta blockers. Number four, we have vasodilators. So there is a direct relaxation of vascular smooth muscles. So its effect is on the smooth muscles of the blood vessels. Examples of these drugs are hydralazine, apresolin, and nitroprusside. Take note, hydralazine is the drug of choice for patients who have pregnancy-induced hypertension. Pregnancy-induced hypertension. So this is the drug of choice, hydralazine. Consideration: assess for peripheral edema of the hands and feet, and take these drugs with food because they can irritate the gastric mucosa. And review the blood pressure every now and then before giving this medication. So before giving hydralazine, you need to check the patient's BP first. Next, calcium channel blockers or the calcium antagonists. Action: they inhibit the entry of calcium into the heart and vascular smooth muscle, therefore, they decrease the cardiac output, dilate the blood vessels, and lower blood pressure. Remember VND. Under calcium channel blockers, we have verapamil, nifedipine, and diltiazem. Next, we have the ACE inhibitors or the angiotensin coenzyme inhibitors or angiotensin converting enzyme inhibitor. What does it do? It inhibits this enzyme, the ACE. It blocks it. So that angiotensin 1 will not be converted into angiotensin 2. These are drugs that usually end in the suffix pril, 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 april, april, april. Examples are enalapril, captopril, lisinopril, benazepril, and for the first dose, watch out for hypotension and loss of taste. Usually, captopril, this is given sublingually and it is fast acting. But make sure, before giving this drug, make sure to check the blood pressure first. Next, the Sartans, angiotensin 2 receptor blockers. They block the vasoconstrictive effect of the RAAS by blocking receptor sites of angiotensin 2. So they end in sartan this time. Example are azilsartan, candesartan, losartan, olmesartan. So anything that ends in sartan is angiotensin 2 receptor blockers. What do they block? Receptor sites for angiotensin 2. So that it won't cause vasoconstriction, it won't tell the hypothalamus to be thirsty for us to drink more water, it wouldn't cause the adrenal cortex to release aldosterone, causing retention of sodium in water. Now, general considerations on hypertensive medications. Remember pressure, pressure. We always need to do pressure monitoring, the blood pressure monitoring, most especially when we are administering fast acting anti-hypertensives. We need to check their blood pressure first because if the patient's blood pressure is below below 120/80, then we are going to withhold the drug. Rise slowly also from the bed because these drugs can cause orthostatic hypotension. So tell the patient to rise slowly from the bed from a lying to sitting position or from a sitting to standing position. Eating must be considered since some of these drugs can irritate the gastric mucosa. And if the doctor has told the patient to take this drug every day, if they are on maintenance, they should stay on medication. Skipping or stopping of these medications is a no-no. So tell them not to skip their maintenance drugs, especially if they have primary hypertension. Undesirable responses assessment. So we need to check for adverse reactions of these drugs. Remind them always to exercise because exercise would be very, very helpful in the control of blood pressure And of course, lastly, to eliminate smoking. Eliminate smoking. So that's it for hypertension. Thank you very much for attending today's lecture about hypertension, and please wait for the lecture on peripheral vascular diseases. Again, have a great day, everyone.